So good morning, good afternoon, good evening, everyone, and welcome. My name is Sherry Evans, and I'm going to be moderating our webinar today. This webinar is about a TXA medication error and covers a topic that keeps me up at night. So thank you for joining us today. Before we start, though, I want to go through some housekeeping so we can get translation on board. Next slide. So this webinar will enable translated captions. So you can see the instructions in English and in French. So you want to click Show Captions at the bottom in the Zoom toolbar at the bottom of the screen. Once you do that, you're going to click the up arrow to show next to Show Captions, and then turn translation on. Select your preferred caption language from the list, and the captions are going to appear in real time at the bottom. So I'm going to leave these instructions up for just a minute so we can have our non-native English speakers choose their language, and then we'll continue. So we can go to the next slide. For our agenda today, I'll give a brief remarks for an opening. We will have David Bishop give his experience with inadvertent intrathecal tranexamic acid at C-section to outline the scope of the problem. We're going to have an interactive session where we're going to ask you some questions, and by Zoom poll, we'll have a discussion as to what experiences you're having. And then we'll hear from Joseph Kiwanuka, who will share with us Uganda's steps to identify and prevent this problem. And then we'll have a Q&A and a closing. So next slide. Please take a moment to introduce yourself in the chat box if you like. We want all questions to go in the Q&A box. Any more casual socializing we'll put in the chat box for right now, okay? So if during anyone's presentation a question comes to you, switch from the chat and put it in the Q&A, and the panelists will be able to see that. Okay, next slide. So again, my name is Sherry Evans. I'm a midwife by training and a doctor of public health. I have been working in various circles on postpartum hemorrhage throughout my career. So as co-chair of the Postpartum Hemorrhage Community of Practice Steering Committee, we are really pleased to bring you this webinar. For a little bit of background, the landmark emotive trial published in 2023 demonstrated the power of early detection of postpartum hemorrhage paired with a first response treatment bundle. Those findings, coupled with an extensive evidence review, prompted WHO to recommend the approach that same year. What resulted was a global scale-up, which has accelerated TXA to the front lines of obstetric care, and this is a good thing. Yet, as with any rapid scale-up efforts, expanded access has amplified an unintended and serious safety concern. The visual similarity in some settings between TXA and bupivacaine, two medications that may now be sitting side by side in many operating theaters, has increased the risk of a devastating medication error, and that is the accidental injection of TXA into the spinal space instead of the intended anesthetic. We believe reports of this error are increasing, and the consequences, especially to pregnant women, can be fatal. This is precisely the kind of signal that demands our collective attention. Not to slow momentum of TXA scale-up through the first response bundle, because we know this can be life-saving, but to protect it and the patients that it's meant to serve. I was in Uganda in December last year, and I had the privilege of attending a meeting of the Ugandan PPH National Safe Motherhood Experts Committee. We had a combination of obstetrics, nursing, midwifery, and anesthesia in the room. As the group deliberated on how best to implement the newly launched WHO consolidated guidelines for PPH, the anesthesiologists and obstetricians were having a side conversation about reactions to TXA that were occurring sometimes in the theater. Having been sensitized to this medication error, my ears perked up right away. What resulted was a coordinated and swift response by the group to mitigate the challenge. As co-chair of the steering committee, I knew that their experience could be some powerful learning that we could share from our platform. So that's why we're here now. Today, we're fortunate to hear from two experts who bring both deep clinical knowledge and real-world implementation experience to this issue. Together, they'll walk us through the scope of the safety concern, the conditions that enable it, and critically, through the experience in Uganda, the practical and evidence-informed strategies that health systems are already using to prevent this error. This is an urgent conversation, and we're glad that you're part of it. So let's begin. Next slide. I'd like to introduce David Bishop. He's a specialist anesthesiologist and currently working as the provincial coordinator for the District Hospital Anesthesia in KwaZulu-Natal, South Africa. He's also associate professor at University of KwaZulu-Natal. His main research interests are obstetric anesthesia, burns anesthesia, and perioperative outcomes in resource-limited settings. He's also involved in distance learning programs and creating online content relating to pragmatic approaches to anesthesia in resource-limited settings. David, over to you.
All right, hello everyone, and thank you very much for the invitation and the opportunity to speak here today. It really is a privilege, and it's wonderful to see so many people from so many different backgrounds and countries online. I'm going to be introducing the problem of accidental intrathecal tranexamic administration at cesarean section. And as Sherry mentioned, my background is that I work a lot in district hospital anesthesia in South Africa, as well as with the confidential inquiry process in South Africa, which is how we detected our first case. And it's through this district setting that we have become increasingly aware of and alarmed by reports of intrathecal tranexamic acid administration. And I believe that context in South Africa has got many parallels for the rest of Africa and the world in low middle income countries, where we have I think, very similar context to some degree. Now, the precursor to the development of this problem was obviously the woman trial that came out in 2017, a double-blinded, randomized controlled trial, 20,000 participants. And because of the fact that one of the secondary outcomes included a maternal mortality benefit with a number needed to treat of just over 250, the WHO recommended the early use of tranexamic acid in the treatment of postpartum hemorrhage. And this led to widespread use of the drug. It was a big change globally, and we started using this drug more than we had before and in new settings that it hadn't been in before. And increasingly, I think you'll find it's being used in non-obstetric settings as well. And my intention today is not to debate the evidence for the use of tranexamic acid. It's clear the drug is going to be around, and it's even being recommended at lower thresholds now, especially as the PPH diagnosis for perioperative or is Caesar bleeding is now 500 mils. But it is important to note that the woman trial didn't report adverse effects that we were worried about. So this was a key finding because we'd been worried about thromboembolism and we'd been worried about seizures. And this trial really helped convince the skeptics that it didn't seem to do harm. But one thing that the woman trial will never have demonstrated is a drug error because of the handling of study drugs in this trial. And if you've been involved in a drug trial, you'll know they come very carefully labeled, and they're running placebo versus actual drug. And so these things will be they'll be handled in different ways for when you introduce the drug in that same clinical setting. So even though they're researched in the context where they're going to be used, they're not handled in the way that context is going to handle them. And I think that's an area that this trial could never have accounted for, and which became apparent after the fact. So just as a follow-up, this study came out this month in the Lancet Global Health. So this is an April 2026 publication done by the same group of people that have done the woman trial. And they showed that giving tranexamic acid to all women giving birth reduced mortality if you gave it where the risk of postpartum hemorrhage deaths was 5 or more per 100,000. And it was cost effective if the risk of postpartum hemorrhage death was 20 or more deaths per 100,000. So the point really that they're making is that it's most effective in the areas where the outcomes are worse. And this map here shows where it would be cost effective. And you can see for Africa that it's only really cost effective at UK prices in the areas marked in sort of powder blue. And in the other areas, it's not cost effective at UK prices, but it is if you can get the drug cheaper, obviously. And they actually tried to factor in the mortalities from tranexamic acid being given intrathecally, although some of their assumptions were based on on things that I might not entirely agree with. I think that they did show that it's not a drug that's going to be removed. Those tranexamic acid deaths are not going to prevent us from using it in these settings. The key is how we implement it. So, in summary, we've seen this global increase in the use of the drug, and it's especially in lower middle income countries where it's being used. The biggest impact is where results are going to be poor, where the outcomes are worse. It's linked obstetric anesthesia in particular. So that's the context that we bring it in, and I suspect that's true for many of us. So we bring in a drug in these obstetric settings, and often these theaters only do cesarean sections. And so the first thing that happens is it's put on the spinal trolley. That's what happens in these theaters. It's being introduced in this new environment, and we don't know how it's been handled and stored, and the woman trial did not look at implementation. So we saw our first case in 2019, and we published this in the South African Medical Journal. And we brought this up. We found out about this case through our national confidential inquiry process. And one of the things that we were immediately drawn to was that the fact that these ampules look very, very similar. So you'll notice there we've got a picture of 3 ampules of tranexamic acid with a bupivacaine ampule, and our case was a simple drug swap error. It was brought about by these 2 things looking exactly the same. And following the publication of this article, I was then inundated with pictures that people were sending me of how they had these near misses in their hospitals. So many of them were telling us that this would never happen to them in the private settings and in the theaters with mature systems. But then they would follow it up a week later saying, we found this tranexamic acid in the bupivacaine box, or we came close, with these various pictures. The one picture, the top right there, that's actually the woman trial. So those are the 2 drugs they used. But remember that those are going to be handled very, very differently from the rest of our settings. Now, we often introduce new drugs into theatre settings. So why should it be such an issue? We have drug checking systems, and we have these ways of preventing drug swap errors. But remember that it's not mature systems we introduce this drug into. And drug trolleys in different contexts, often you just have one in the room and everything goes on that trolley. And how you handle that drug obviously becomes very important. Now, in 2019, shortly after the woman trial, this article was published in Anesthesia, and they highlighted the fact that tranexamic acid was being given intrathecally during spinal anesthesia across a variety of contexts. And it was accompanied by an excellent editorial by Arvind Palanisamy and Mike Kinsella, which cautioned that the use of tranexamic acid, while it was well-intentioned, had the potential for catastrophic collateral damage. So, and they made the point that we have to live with the risk, but we have to find ways to manage it down towards 0. And remember that when we give tranexamic acid in a spinal injection, it's drawn up into a syringe. So having a special Lua locals, or in other settings like oncology, it's a simple drug swap error, and where you've drawn it up in that syringe. And once you've drawn it up incorrectly, all of those other systems can't help. And in this editorial, they highlighted the fact that you can see these are the tranexamic acid cases. You can see that recent increase in the number of these events. And this was just prior to the massive introduction of tranexamic acid globally. They talked about the mortality rate being something like 50%, but in this series, where there were 21 cases, there were only 7 cesarean sections, and 6 out of those 7 cesarean sections resulted in mortality. So it's clear that it's an absolutely catastrophic error. And one of the things that these authors recommended at the time was that they felt that the tranexamic acid should be stored in a separate location outside the operating theatre to limit the possibility of picking up the wrong drug. And to be clear, they're not recommending that we don't give it timeously. They're just suggesting that we think very carefully about the storage site, which I'm going to come back to. Now, following this, we had an alarming number of reports in South Africa. And depending how sure you think you are of the report, there was something like 10 to 15 cases in the 1 year following that publication of our one report. I was personally aware of 7 of these cases where intrathecal tranexamic acid had been given at cesarean section. 5 were fatal and 2 had significant neurological morbidity. And they all occurred in district hospitals with anesthetists that weren't specialist anesthetists or full-time anesthetists. They were what we call occasional anesthetists, people who are generalists but give anesthetics when they need to. And very worryingly for me, they all came from 2 out of the 9 provinces in South Africa where I was in contact with these doctors. And there was one, these were also reported to another obstetrician who I was in contact with, who had heard about a number of other cases. And we felt that there were probably somewhere between 10 and 15 in that year. In 2 cases, there was a pathognomonic presentation, and we were sure that this was what had happened, but then there was a subsequent denial of the error. Because who really wants to either publish this or bring this to people's attention when it's so clearly an error that has resulted in a poor outcome? So the problem really is that these cases are very likely underreported, both because people were not aware of what had happened and also because they were concerned about medico-legal outcomes. And finally, I think they're often misdiagnosed, which I'm going to come to as they're often diagnosed as a preeclampsia or eclampsia. Following on from this, we then were involved in this publication, which was published in 2022 in 4 major obstetrics and gynecology journals, which were the American, British, International, and European Journal of Obstetrics and Gynecology. And this highlighted the growing international concern. And I'm going to come back to some of the recommendations in this report. And I just want to touch briefly on what happens when you give tranexamic acid into the intrathecal space. We know that it's a synthetic lysine analog that acts to reduce fibrinolysis through competitive inhibition of plasminogen binding sites. That's what we're giving it for. But it also antagonizes GABA and glycine receptors, which causes profound neuronal excitation and leads to overwhelming sympathetic stimulation. So when you give this to a mother, intrathecally, the concentration is 7,000 times higher than if you'd given it in the normal fashion. It antagonizes those receptors, and the first thing they'll complain of is myoclonus and pain. This is often followed by seizures and sympathetic activation, which is then often complicated by cardiac arrhythmias, and patients go into pulmonary edema. Now, in pregnancy, there's a reduced CSF volume as well as the increased dural sac surface area. So this facilitates spread, and this may result in higher concentrations, which may lead to this higher mortality rate we're seeing. But also, if you think about the setting where you've put in a spinal anesthetic, the mother complains of pain, the spinal doesn't work, and then the mother has a seizure and has a very high blood pressure. And that for many people is what eclampsia looks like. So it's incorrectly diagnosed as eclampsia. And we had a referral where somebody phoned and said, we had this patient who had a failed spinal, she complained of pain, and then she has developed eclampsia. And when we asked them to look in the drug vials, it turns out that the tranexamic acid had been given intrathecally. And so these sorts of cases may be being reported as eclamptic events when in fact they are this drug error. I'm not really going to get into the treatment too much because I think that the focus of this problem needs to be prevention rather than treatment. But there's not a lot of specific treatment. Supportive treatment usually involves general anesthesia. They require ventilation and cardiovascular support. Seizures are hard to manage. They're resistant seizures. Thiopentone has been used, although, as we know, it's hard to get a hold of thiopentone infusions now. And probably the only specific treatment people are using is CSF lavage. And there's a number of ways. People either do repeated 10 ml, take 10 mils of CSF out and replace that with 10 mils of saline, or 20 mils once off. And that treatment has been used in other settings like inadvertent intrathecal potassium administration. But if you think about the sort of requirements for treating these patients adequately, the areas where this is happening, these treatment modalities are often not available to those clinicians in that setting. So the key here is to avoid it ever being given intrathecally. And following that article as well, there were also appeals to the WHO and the US FDA, and they put out warnings suggesting a number of things, but the key messages were that we should store tranexamic acid vials separately from other drugs, and in a way that made the labels really visible, to maybe add an auxiliary warning label to the vial, to obviously check the container label. And then they suggested barcode scanning, which is not a thing that we have available in most of our hospitals in South Africa, and I suspect in most low middle income settings aren't available. But obviously, nice thing to use if you've got it. So we know the value of and the need for tranexamic acid, but there's a danger that these events are going to offset some of the gain that you get from using it. And so our recommendations have been about information sharing with both health workers and management in hospital, implementations of strategies and protocols which are then overseen and audited by clinical people and management within that hospital, and very specific protocols for hospitals which include physical separation of the drug from the anesthetic drug trolley. Locally in South Africa, the messaging that I've been using really in the district anesthesia education is that you never ever store tranexamic acid near to the bupivacaine. You never store it on the same trolley. And if possible, you put it in a sealed box. We now label our boxes as a hemorrhage kits, and we keep our tranexamic acid in that, or we put the tranexamic acid just outside the theatre. And when we've initially sent this message out about storing it outside the theatre, there was some pushback because people felt that we were meaning that a time-sensitive drug was being stored far away from where it would be needed when you need to use it quickly. And I just want to point out that there are lots of time-sensitive drugs in anesthesia that are not stored primarily in the theatre. One of them is the refrigerated drugs. So succinylcholine is often stored just outside the theatre in a fridge. If the tranexamic acid was stored the same distance as that fridge, that's what we're talking about. So it's stepping outside the door and getting it, not outside the theatre complex, just not in the theatre room. And so we're talking about a minute's delay. These drugs need to be given within minutes, and we acknowledge that they're time sensitive. So we're not talking about in the wards or in the pharmacy. We're just saying perhaps not in the room or in a different spot. And anecdotally, this is what we've introduced, and the messaging that we put out and these suggestions, certainly in my province, have resulted in we haven't been seeing these events occur anymore. So, in fact, this article in IJOA in 2018 was somewhat prophetic. They were worried about the collateral damage that was coming, and they were highlighting the fact that when we get new evidence, that even though it applies to our context, the implementation of that evidence is not maybe as simple as we think. And the fact that we brought it in this way was something that I think the anesthetic and obstetric community didn't consider entirely what was going to happen to this drug. It was almost like we knew it worked, but then we didn't know how to implement it. And I think that there also needs to be a paradigm shift where we stop thinking about medication safety as an individual performance problem. So often we think, okay, we just need to remind clinicians to remember to check, and they must be careful. But actually, it's not. If we approach it in that manner, we're going to be relying on individuals in specific circumstances. And what this is a systems problem. And so we need to fix healthcare systems that manage these drug problems. And if we focus on the systems, we'll take the pressure off individuals in these settings. So I'm going to finish with just 3 slides that speak to systems. The first is that one needs to recognize that medication error is common. 1 in 20 drug administrations in theaters are actually a medication error. 1 in 2 operations have some sort of a drug error during that operation, even if that's a dose error. It's often a mild thing. They're not all catastrophic. And sorry, I just need to move that. This problem of medical error is a complex issue. And there's cognitive processes, there's decision making, there's medication design, position, shape, size, coding, the effects of distraction in theatre, fatigue. And then there's the systems that we bring in. So 2-person checks are what everybody usually touts, but these can actually be ineffective, and they're hugely influenced by how you do them. So for instance, if you say, I'm holding my bupivacaine amp up, do you see the bupivacaine? The person's going to say yes. And so there are ways in which we use these systems. For instance, you hold it up and you say, what do you see? And they read it off the label. So there are lots of things that we can bring about to make our systems better. And the key is that we make it easy to get it right. We make it an easy system for people to not make errors. As with all safety management interventions, systemic changes that produce conditions that prevent unintended actions are preferable to local and individual practitioners inventing unique workarounds. So it's better to have systems that we all can just use rather than each hospital comes up with its own solution. And part of that is a culture of humility to accept that we all are going to make errors. So we must plan to do everything with this in mind. And this article that I've got referenced here is really a nice look at it if you're looking at medication handling. And it focuses on reducing drug administration errors in anesthesia by designing these systems around our own cognitive limits rather than expecting perfection. So it advocates reducing environmental distractions, having good drug checking system, and also stressing that the human factors approach, where you rely on just your own vigilance, is ineffective. And rather having standardized environments or protocols are more effective than relying on individual memory. So if you go and look this up, you'll see there's articles with something like 140 recommendations in them. But the key is we need to look at our systems and revise them where appropriately. We've really got to get the message out there about this problem and inform, educate, and train. We need to start bringing a medication safety culture into these environments where these errors are occurring, not only to prevent intrathecal tranexamic acid, but also because they may prevent other drug errors that are occurring and we may not even be aware of just because they haven't got those catastrophic outcomes. Position coding is where do we store this drug? And I'm a huge fan of putting this drug in a different place. And then when you find it on your trolley, stopping the theatre and saying to everyone, we really need to not store tranexamic acid anywhere near bupivacaine. So it can't ever be picked up like this. Stray ampule policies. If you think about your own theatre, what do you do when you find an ampule that's just lying around? And often what happens is people put it back in a box. And that is a major source of drug error because you tend to check the box and forget to check what's in the box. So when it's put in the wrong box, people don't check it as it comes out. They check that they're holding the right box. We often get talked to about, can we change the appearance of the tranexamic acid ampule? That would be lovely, but both bupivacaine and tranexamic acid are patent expired, which means they're made by a phenomenal number of companies. And trying to control the appearance of these drugs is very, very difficult. You can put stickers onto the drug, but to actually insist on asking them to produce it in a certain way is very difficult to control, as we have found out. And then when you, in these settings, audit and appraise, find ways to reassess your systems and see if they're working. Finally, as the last message of this talk is just to be proactive, not reactive. We've often given this talk and sent this message out, but what really makes people respond is when they have their first event of an intrathecal tranexamic acid administration, which usually results in a mortality. And it's a really good idea to learn from other people's stories rather than being the one who had to tell the story of this era. So if I can really urge one thing, it's to go back to your theaters and think, where do we store this drug and how do we prevent it ever from going into the intrathecal space, so that you have at least been proactive rather than having to react to a tragedy. And I'm going to stop there. Thanks for your attention. And I'm now going to stop sharing, which seemed to be what I started with.
Excellent. Thank you, David. I really appreciate the couching the problem as a systems issue, because we do tend to put it on the shoulders of the single person who is responsible for the injection when the system was not set up for success for that individual. And the culture of humility too. We all make mistakes. So how do we support the scale up of this medication in a safe way by having safe systems in place? Okay, so for anyone who has questions, we're going to do a question and answer at the end. But if Dr. Bishop's talk has put some questions into your head, please put them in the Q&A for when we get to that part of the session. So Caroline, I think we're going to start some Zoom polls. And what we want to do is understand from you, as David said, this medication error can look like something else. And so we believe that there is some significant underreporting. And so we want to ask some questions just anonymously to hear from you, like what your experiences are. So, Caroline, are we ready? There we go. Okay, so I'm assuming everybody can see this first Zoom poll question. So how is tranexamic acid used in your setting? Select all that apply.
Give it a minute or two for people to respond. I see already over 70 people, so that's excellent.
Looks like we still have people responding. Great. Keep it going. And I think what we're seeing is the trend that it is being used for treatment of postpartum hemorrhage. I'm happy to see that prophylaxis or prevention at vaginal birth is exceedingly low. The WHO consolidated guidelines did come out with the recommendation that TXA should not be used either at C-section or at vaginal birth for prophylaxis. And we do know that if it's used prophylactically at all cesarean births, that does increase the risk of that drug. So if it's used on everyone in your theater at C-section, it increases the risk that those drugs, for convenience sake, might be right next to each other. Let's see, do we have more people chiming in? I think that one looks like we're not getting any more responses. Okay, and I'm thrilled to see that the vast majority it's being used for treatment of postpartum hemorrhage. That's great. Shall we do the next one? Do I need to, let's see. Okay, there we go. Question 2. Have you experienced any of the following challenges? Select all that apply. So side effects or medication errors related to TXA that you know of, but also an uptick in eclampsia in the theater in your setting. And so we are seeing, recognizing that we've got around 250 people on this webinar right now, that we've got, looks like around 50 or so far are seeing side effects or medication errors, and a smaller number, an uptick in eclampsia. And people are still answering, so we'll keep it rolling for a minute. So if it doesn't apply to you in the next question, if there is, I think we have one more, just don't provide an answer. All right. There we go. And this is a short answer. What factors might contribute to these problems? So for those of you that saw either an uptick in eclampsia or you're seeing medication errors or side effects from TXA, please jump in and let us know what you think might be contributing to those problems. And I'm seeing some people put some comments in the chat about what they are finding. Victoria says in their hospital in, oh, it just jumped on me. They usually keep TXA in the labor ward while bupivacaine in the theater. And Rashid says it's important to report to the manufacturer as well. Okay. I do see the numbers still going up. All right, why don't we go ahead and close it out? People still can put things in the chat if they like, and we'll see what Caroline can share back with us.
Maybe we send a recap since this is short answer as part of our follow-up.
Okay, I'm guessing with 39 answers, we probably have lots of text.
A lot of great responses. So thank you so much, everyone. And there's just one more question to ask.
Okay, let's go to that one. And so yes, as Caroline said, we will, as part of the recap to the webinar, we definitely will ensure that you hear from your co-attendees what they had to say. So this is another short answer. Have you put any measures in your setting to prevent inadvertent intrathecal administration of TXA? Short answer. So for this one, go ahead and type in whatever you want. I think it'll be the same. I think we're going to have a number of responses that will be a little bit too much to share here. We'll give it a minute and see. And then next we will be hearing from Joseph Kiwanuka from Uganda about the Ugandan experience. Okay, now I'm really excited to introduce our next speaker. Joseph Kiwanuka is the immediate past president of the Association of Anesthesiologists of Uganda, and he is here with us today to share the experience that they had in Uganda after seeing some challenges with introduction of TXA. Joseph, over to you.
Thank you very much for the introduction. Okay, I'm Joseph Kiwanuka. I'm an anesthesiologist practicing in the southwestern part of Uganda. And I would like to share our experience of Uganda regarding this topic of intrathecal tranexamic acid. First, I'll give you a background of what Uganda is. We are located.
Joseph, I can't hear you. I think I lost you. Are you there?
I'm here. I'm just trying to make sure I can see the slides.
Perfect. Okay.
For some reason, they can move it. So Uganda is found in the eastern part of Africa, neighbored by Kenya, Tanzania, and South Sudan, and the DRC, for those of you who may not know where we are at. And regarding anesthesia, we have three cadres currently practicing anesthesia in the country. First is the physician anesthesiologist, and then we have two non-physician anesthesia cadres. One holds a degree after 4-year training, and then the other is a diploma holder after a 2-year training. In many of the cases, the non-physician anesthetist is the one that is found at the lowest center that does surgery, and that is called the Health Center 4. And many a time, you are finding that you have 1 to 2 of them at a time who provide anesthesia for throughout the year, 24/7. There are challenges that come with that, like we shall be seeing later on. Then we also have cesarean sections dominating the surgical landscape, and over 90% of them are emergency cesarean sections. The emergency cesarean sections dominate the surgical landscape, and we still have hemorrhage contributing to the highest amount of maternal mortality in the country. Later on, we shall look at the critical care capacity that is essential for the management of this particular problem or issue that we are looking at. Cesarean section rate nationally is put at around 11%. Some of the centers, especially the referral centers, at about 30 to 40%, whereas some centers have also been noted, especially the private setups, to even have cesarean section rate of up to 70 to 80%. I'll be looking at this via the SWOT analysis to try and highlight what the issues are. So the system, we are set up, the Ministry of Health adopted the local maternity and newborn care system, and I think it was benchmarked from the UK. And under this, you have the national LMNS committee, and then under that, you have the regional committees, and all the health centers belong to one of the LMNS systems. Under this, the idea was try and find local solutions to any of the problems that you are having. And unless it overwhelms the local system, that's when it would be sent to the national system. These LMNSs meet on a regular basis, weekly at that. The national committee meets every Thursday morning via teleconference. The local systems, most of them actually meeting on Tuesday mornings. And then there is a national mortality audit that happens every Monday morning, again via teleconference, where all these mortalities that have happened countrywide could be presented. But it is a rotation basis, and every once in a while, one of the local systems actually does get to make a presentation. Every maternal mortality is notifiable up to the ministry level, and that was one of the reasons why this came to light at that particular point in time. We have essential maternal and newborn clinical care guidelines that promote, that have the intervention that show the use of tranexamic acid when it should be used, and thus it has also been adopted quite quickly. I'd also like to highlight the fact that Uganda was one of the centers that actually participated in the woman trial, and that was the participating hospital was the national referral, which is the Mulago Hospital. So under weaknesses, we find that we find a number of weaknesses in this. The first has already been highlighted, which is look-alike packaging that happens all over the world. If you look at the top two pictures, you'll see that you have tranexamic acid. There are two ampoules of tranexamic acid, one of them being the other one being spinal bupivacaine, and on the right side, on the top picture, one of them is actually a muscle relaxant. This has been a very big problem, and we think this was one of the leading contributors to the challenges that occurred at the time. Why would there be challenges? The other leading contributor was the number of personnel that are in the operating room at the time of a cesarean section. I've already highlighted the fact that at the health center 4, you already have a limit in the number of people who are in the operating room during a cesarean section. Most of the time, you're going to have just 4 people: the anesthesia provider, the surgeon and his or her assistant, and then a midwife who comes to receive a baby. And when you look at that and having over 90% as emergencies, many of them being category 1 cesarean sections, then you find that during the preparatory phase, everyone is in a silo kind of setting, trying to make sure that their equipment is quite ready and the medications are quite ready. So that has put the use of checklists down so low that we are having quite a lot of challenges. The other thing that was already been highlighted is the poor storage practices. And again, when you don't have an assistant to help you work around the challenges that you have, then you are likely to end up with what you already have. A lot of the places have utilized boxes that are labeled, but like Dr. Bishop already said, if you have the wrong drug in the wrong box at that point in time, it may be extremely difficult to actually get the right thing in. Uganda also has a weak medical error reporting system. For one of the reasons being the fear of punitive action that may come when one reports a drug error during that time. So we believe that even with the mortalities that happened, there is definitely a lot of underreporting of these errors. On top of that, when you look at our National Drug Authority, that would be responsible for clearance of any drug that is coming into the country, it has not publicized to so many of the frontliners the means with which to report adverse drug reactions. Whereas they have a WhatsApp number and an email address, these are hardly used. But we're also finding that there is a very big delay between the time that these are noticed and any kind of follow-up at that time. So sometime last year, around August, the National Drug Authority recalled two preparations of spinal bupivacaine. And they did not actually give a very clear reason at that point in time. But we believe it was from the pressure that had arisen from the increased maternal mortality that was attributable to failed spinals. And looking back, it was quite obvious that this was a very wrong drug being given in the wrong route at that point in time. But what they did was reactionary and actually just recalled the medications. And at that point in time, the Association of Anesthesiologists of Uganda actually came out and got involved because these particular errors were also leading to the denial of a very reliable and a very necessary service to quite a number of the patients within the country. Now, when we look at what are the threats, we definitely have a lot of tranexamic acid use, especially in the emergencies. Earlier on, I said hemorrhage is a leading contributor, and every so often, you end up having to manage a patient with a ruptured uterus or antepartum hemorrhage or postpartum hemorrhage. And the guideline already, the national guideline already highlights when to administer. We still have the challenges of lack of dedicated space, appropriate dedicated space for the preparation of some of these medications. So there could be a mix-up at that point in time. So we are not able to, with the lack of personnel and the lack of checklist culture, then it becomes very difficult to actually fight this particular issue. The other challenges that come with the harsh mentality that has been common in the medical field. something happens, an event like inadvertent intrathecal tranexamic acid could happen, but the system may want to shut that down so that you end up not having to make the due accountability in order to make the particular interventions that would address this problem. So it is still very, very common, and it is something that will take a bit of time for people to gain trust to actually notice that when you report this, then you are going to have much better outcomes. The other thing would be the blame culture of who is really responsible for this. And at the end of the day, it's going to be, well, the person who's administered, and that is going to be the anesthetist. But like it was already highlighted, the particular symptoms are also common with the eclampsia. So it's not uncommon for people to go ahead and blame the eclampsia other than trying to actually highlight what the problem is. I talked about critical care, and we've already seen from the previous presentation that a lot of these patients are going to end up in critical care. We are not very much gifted when it comes to critical care services. When you look at the map of Uganda over there, those red polygons are the ones where you have critical care services in the country of 42 million. This has not really changed much over the last 5 years when that publication came out. And what brought light to that publication and a lot of press, including the New York Times, was the fact that we are getting into COVID management at the time. 6 years down the road, we still have those same places outside of the capital city, which is Kampala. Kampala's numbers might have increased due to private input, but still very, very difficult to access those services. Many of the beds are usually full, or it's extremely unaffordable. So it becomes very difficult to manage these patients, and hence mortality has increased. One of the cases happened in the West Nile region, and it's in a district called Nebi. And when someone called about the patient, the initial management was initiated, but this patient actually had to be moved hundreds of kilometers across to try and access an ICU bed, which is in Gulu in the Acholi sub-region. And unfortunately, this patient didn't make it. So it becomes very, very difficult to actually manage these complications. And yet, there are a lot of success stories where an ICU has been close at hand. Investigative capacity is also limited because sometimes you also want to roll out a number of things, but laboratory services may also be limited during that time. However, there are still opportunities which are already being attempted and which are already in the pipeline. First of all, we already have the maternal and newborn clinical care guidelines, and there are already issues about revision to try and highlight some of these issues. Like Dr. Bishop has already said, in some places, the tranexamic acid has been put a bit far away. Unfortunately, when you have the single anesthetist with no assistant to go and run for this drug, then it becomes untenable at that point in time, and hence that drug keeps getting closer during that time. We've had conversations about preparing an anesthesia for cesarean section kit for the anesthetist, in which you would have the gloves, in which you would have the ampule or vial of tranexamic acid, and the spinal needle, and then the syringes. And we think that this would be helpful. And we are looking at the national medical stores, which supplies most of the sundries and the medications in the public space that is used by most of the Ugandans. And we believe that this could be a workable solution and help with some of the challenges we're already seeing. There is engagement with the National Drug Authority to try and see, to revise the packaging of drugs, certain categories of drugs, to try and overcome this. And then lastly is to also try and, with the growing capacity of anesthesia providers in the country, we're also pushing for the component of support supervision to go and work in these remote places and work with these anesthesia providers so that we actually can be able to overcome some of these challenges and try to establish some of these low-cost solutions to overcome this. I thank you very much for listening.
Thank you so much, Joseph, for sharing the experience in Uganda. And I have to say, I'm humbled and really pleased that the Uganda team was comfortable and able to come forward with this challenge and to be able to share what you're doing to mitigate it. It's really important. So there are already some questions that have popped into the Q&A. Before we get to those, I do have at least one question for each of you. So I'll start with you, David. Because the medication error can masquerade as seizures from eclampsia, as you said, or some kind of allergic or drug reaction, how do you propose, whether it's at the facility level or a health system level, how do you propose people begin to even understand if it's happening? You know, what are some concrete steps that they can take? Because we don't really have data for all the reasons that you said and that Joseph said, the hush culture, the blame concerns, and also if it looks like eclampsia, it's easy to chalk it up as that. Do you have any thoughts?
So are you talking about how we would pick up that we've made this particular in the clinical scenario?
Yeah. So if people go back to their sites thinking, oh, we don't have this problem, we don't have an error, but maybe they do and it's misclassification. So what are some concrete steps for those who don't think that there's a problem that they could just to confirm that they don't have that problem?
Yeah, so I mean, I think there's two aspects to that. There's when the event occurs, and then there's trying to prevent to see if you're at risk of the event. So when the event occurs, that comes down to pattern recognition. And what we're talking about here is the setting of a spinal anesthetic that fails. So you see no effect of your spinal anesthetic, which is then followed by, and these mothers complain of quite dramatic pain. They get this cramping pain in their legs, and it's followed by seizures and sympathetic activity. And so that pattern recognition is important. And I think the step that we often find has not been taken is that when you see that occurring, there's you need to manage the emergency. But those vials shouldn't have been thrown into, they normally, when you break the vial, they should go into a container that is held for the length of the operation. So part of drug safety is that you don't throw them into a general storage bin. You put them in a discrete sort of container, and you are able to go and review what you've given. So often we find out that the drug error has been made because people recognize the pattern, they phone for help, and when you go back to those ampules, you can see what drugs you've been given. So part of drug error culture is that you don't discard your ampules until the operation is finished. And the second thing that I would encourage, if you think you don't have a problem in your setting, is you don't want to diagnose the problem because you had an event. And after we gave this talk initially, a talk similar to this in South Africa, I had a number of people saying they don't have this issue, but they went and checked their theaters. And that's the discipline, is to go and see, well, where is my tranexamic acid being stored in the theater? What do my systems look like? And people went through their bupivacaine containers and found tranexamic acid sitting in there. And so they were sending me these pictures saying, we didn't have the event, but look what we found. And again, we're not talking about taking this drug and making it inaccessible, But somehow we've got to get it away from the spinal trolley, getting it away from things that could be put intrathecally. And that could be spinal trolley drugs separate from anesthetic drugs. It could, you've just got to look at physical separation. So that pattern recognition, storage of ampules, and then go back and make sure your system is not putting you at risk of this error, because it just takes one, and that's what you're trying to avoid. It's a never event.
Right. Thank you for that. So I'm curious for those who work in theaters that are on this webinar, if you could put in the chat, I'm just curious. What David said is there should be a bin where any ampule or drug that's used, it goes right there. So it doesn't get thrown in the sharps container until the end of the case. So that's a systems issue and a systems safeguard, or at least so you can recognize right away what the error might have been. Put in the chat if you're comfortable, like, do you have that particular practice in your operating theaters that you have a bin where anytime an ampule is broken, it's set aside so it can be reviewed later and not discarded till the end of the case? Just curious if people are comfortable doing that. I'd like to hear. So, Dr. Joseph, you talked about the hush culture and the blame culture, and it's very important. What do you think is the best way to have at the facility level potentially, but also at the health system level? What is the best way to reverse that course? What have you found that works? Is it an issue that you're still working in Uganda? It sounds like you are, but do you have any tips or pearls of wisdom to kind of remove that blame culture and the hush culture and to have that culture of humility and openness and problem solving?
Thanks so much for that question. Well, to overcome the harsh culture, we must have a way to put forward the fact that any kind of audit is to try and improve a system. For the places that have regularly done morbidity and mortality audits, I think what has happened was identify where the challenges are. Many times it has not been related to anesthesia, or many times in my experience, say in the hospital where I practice, there are times when an audit can happen, despite the team having been part of it, they are left out. And therefore, the other team gets all the ability or gets all the space to actually just do a blame. But what we've tried is to be open and to try and address what the root cause is. And we've seen a change in the approach to some of these cases. It requires that there is trust, that there's no one going to be left out to hang, to dry, but also that you are actually actively working towards finding a solution to some of the recurrent system errors, or trying to support whoever has been found to be wanting in some of the areas. I think that has always made a very big difference. So it depends on how the system is set up to handle some of these challenges. And if we are open and very supportive and trying to find the solutions to the problems, then surely we can overcome the harsh and blame cultures. Thank you.
Thank you for that, Joseph. So we have an interesting question. This is for David. What longitudinal data do we have that shows that these incidents are rising, or is increasing incidents just assumed based on the changing guidelines that mean TXA will be used more?
Thank you. And it's a good question. And unfortunately, I haven't got a great answer, because what we found was that we picked up our one case in South Africa, which came through the confidential inquiry and which we wrote a warning linked to. And then we started getting these reports in of events that seemed to fit the pattern. And some of them we felt were confirmed. But these reports, people are very reluctant to officially report them, and many of them were later denied. And so we saw, and like I said, it was somewhere between 10 and 15 cases in the first year after tranexamic acid was introduced. And we only heard about these cases because of our connection to these areas. And in the areas where we weren't connected, we weren't hearing about the cases and they weren't being diagnosed. So in terms of longitudinal data, it's a bit frustrating because they're not officially reported, they're not published. So it's the sense we've got that this is probably a much bigger problem, but there's a necessary degree of speculation. And I know, speaking to some of the women trial authors, that they're frustrated about this because this message almost pushes against tranexamic acid, and yet we aren't able to produce the data they need to engage with, and which is a fair criticism, but I think it comes about through misdiagnosis, poor reporting mechanisms, and a fear of medico-legal consequences. And so we haven't actually got that. We had that signal in South Africa. Since we've put out our multiple messages and have done a lot of education, we've picked up one or two sporadic cases, but really not the numbers we were seeing before. And it's more our suspicion that this is a global problem in these sorts of areas than it is with confirmed longitudinal data. And I think just to link to that as well, we've been talking about tranexamic acid use going up. With the new definition of PPH being at 500 mils in Caesar instead of 1,000, that's going to dramatically change how you measure the incidence of PPH. And in my own hospital, I've just finished an audit where, by the old definition, our incidence was something like 3 to 5% PPH at Caesar. By the new definition, it's 30%. So if we start bringing in tranexamic acid for 500 mils, we're going to be giving it to almost 1 in 3 cesarean sections if we measure blood loss appropriately. And that sort of increased usage is going to come with drug errors, one would expect. But again, hard data is hard to get hold of.
Yeah, thank you for that. And yes, and it was more by happenstance in the middle of, a very deep discussion with the Ugandan Safe Motherhood PPH expert committee that this kind of bubbled to the surface and they took, kind of firm and decisive action. This question, I think, is very interesting. And David, I see that you answered it in the chat. So if people can look at the Q&A, you can see some of these questions. This one from an anonymous attendee actually said, we're talking about inadvertent intrathecal administration of TXA, but what about the opposite? If they're lookalike drugs, why is bupivacaine not being injected IV when it's supposed to be TXA, which I never thought of that until now, but it does seem like that mistake should happen. Could be happening. Do you have any insight? And then I'll turn it over to Joseph to see.
I just muted yourself. Sorry.
Oh, sorry.
Sorry.
Yeah, go ahead.
Okay. So yes, drug errors can happen both ways. So we could be putting the tranexamic acid intrathecally, and we could be putting the bupivacaine intravenously. But we haven't heard reports of bupivacaine being injected. It doesn't mean that it's not the case. And you can survive an intravenous bupivacaine injection, although if you give enough, it is also usually a fatal event if you don't have intralipid. My suspicion is what's happening is that the problem is drugs going onto the spinal trolley, ending up with the bupivacaine on the spinal trolley. So it's more a problem of the wrong drug being given intrathecally. It's quite possible that other drugs have ended up going into spinal spaces, but they don't cause the fatal reaction that you see with tranexamic acid, and this is why it's such a catastrophic event. So yes, it could be happening both ways. But my feeling is that we are used to bupivacaine living in a certain place, and people are the other way. This would have been a problem for many, many years. It's been the introduction of this new drug that was never on the spinal trolley before and has now ended up there or near the bupivacaine. So we've noticed it seems to be one way, but it's certainly a relevant question, and we should look out for drug errors in all sorts of in the other direction, as this person's pointed out. But at least in our experience, we haven't seen that, and people are very attuned to the risks of intravenous bupivacaine. So usually, the incidents we see are people that have given it intravenously by mistake when they were doing blocks. that tends to be our experience with bupivacaine overdoses, is that they're doing some sort of nerve block and they've stuck it into a vessel. But we haven't seen it, but yes, it's a good point.
Thank you for that. So, Joseph, what about you in Uganda? Have you seen the reverse mistake with bupivacaine given mistaken IV?
Well, thank you very much. I'm aware of one case where that happened. Only this time, I think it was swapped because the ampule for ondansetron looked like that for bupivacaine. So bupivacaine got given IV. So when you look at the ampule will have just 20 milligrams in about 4 mils. For some that are more concentrated, then you only have 2 mils. But commonly we have the 4 mil ampule. So when you look at the dose per kilogram, then it is really on the much lower side. Probably that's one of the key reasons why these have not been reported, because that particular error may be forgiving, unlike the reverse, where you end up with the intrathecal tranexamic acid. Thank you.
Okay, thank you for that. So I'm reviewing the questions, and I see Yergal Admasu has his hand or her hand raised. If you'd like to put a question in the chat, we can't unfortunately bring you off of mute, so put your question in the chat or the Q&A. Okay, so I am seeing, can tranexamic acid cause DVT or put postpartum mother at risk of DVT? I see, David, you're typing an answer. Do you want to go ahead and just take that?
Sure. It's a good question because it's the thing we were all worried about. We were worried about DVTs and procoagulation, and we were also worried about seizures. And one of the things these tranexamic acid trials have been good for is that they have to some extent alleviated these concerns. So the woman trial had 20,000 participants, 10,000 got tranexamic acid, 10,000 didn't. And there wasn't an increased incidence of DVT. But for those who were actually part of the woman trial, they'll also know that it wasn't as if they had the resources to do ultrasound scans of everyone who received the tranexamic acid and follow them up long term. So while there wasn't an incidence of reported DVTs, one can't say, no, the risk is 100% not there. So it remains a thing that we are concerned about, but all of these big trials coming out where they've used a lot of tranexamic acid seem to be dampening that concern down. So currently, we are saying that it doesn't seem to increase the risk of DVT, but for me, it's one of those issues that I continue to watch, because it's something that we should consider. So in terms of the global recommendation to give tranexamic acid, the reason that global recommendation came out, I think, is that the evidence seemed to be that it's not a significant increase in the incidence of DVT.
Okay, thank you for that. So I wanted to ask, this is a question just in advance and listening to both of you speak. David, you said there's over 140 recommendations that this group came out with, right? And so what do you do with that? So if whether the facility or the health system level, whichever you want to take, and maybe I'll have Joseph do the other one. But if you suspect the error is happening and you've got these 140 recommendations, what is the first thing that you think they should do at facility or at a national health system level?
Oh, it's an excellent question. And if you read through that article, you can get a little bit of analysis paralysis. There's so many things that you're supposed to do. And to my mind, the key step to take is that an institution sits down and thinks, what is our approach to medication handling? And really, once you've got buy-in from a team that we are going to think about medication safety in an institution, the rest actually follows quite easily, because there's a number of processes then that you will then do. You will start to think, okay, what safety measures do we want? How are we going to check that our medication is being given safely? And what practices can we introduce? And as soon as you can introduce that, it's an organizational culture that you've got to try and establish in your theaters that says, we think taking medication error seriously is an important thing. That hump, once you get over it, then once everyone buys into that, I think that's when you see change. And what you've really got to avoid is one person coming in and kind of trying to do that on their own. What you have to do is get that whole team into an organizational culture which says this is a thing we take seriously. And after that, the individual institutional solutions you find to your particular problems are they're quite different in their expression, but they all have those key elements of an organizational culture, auditing what you're doing, physical separation, establishing systems that prevent individual errors. And you don't need fancy barcoding and all of these sort of high-tech solutions. What you require is a team that's interested in it. So for me, that's the biggest hump, is getting people to believe that there could be an issue that they are going to try and address.
Thank you for that. And yeah, your surgery is a team sport, and you got to bring the team all together around it for patient safety. And so for our participants, we will be sure to share these resources. A number of you are asking for some of the papers and information. We will share that out in our recap. I do want to ask Dr. Joseph what he feels like is if a setting, whether at the health system or facility level, is identifying this error, what is the first step you think they should be taking?
Thanks very much for that question. This is mainly a system problem, and it's important to identify at the particular health facility what are the possible causes. So it requires that we get to audit entirely the path of one of all of the medications, like Dr. Bishop has said. If we go and put 140 recommendations at any of the facilities, or whatever the setting, they're all bound to fail. But if we tease out what is relevant to each of the facilities, then we are likely to come out with the right solutions that help. When we find, like it was highlighted before, when we find that there is a shared trolley for the spinal medications and those of the IV medications, then you've already increased the likelihood of the wrong drug administration. But if we just separate them, then we've already reduced the chances of this happening. Where I'm practicing, someone came up with a solution of labels, just of all the anesthetic drugs that have been prepared. And you have relaxants, you have analgesics, you have this. And if you just position those syringes in each of those places, then you've already reduced on the chances. But that is just on the cut. And all it took was a bit of tape and a marker, and that happened. So we've got to go down to each of the facilities and find out where the loopholes are, and then we can try to design systems or to try to put the solutions that are relevant to them and that are practical. And that's how I think we can be able to overcome the likelihood. Thank you.
Thank you for that. And can you tell me, Joseph, if my understanding is correct, I'm not sure the vehicle that was used, but in Uganda, was there a policy made at the national level somehow, or, how was it instituted, but that TXA should never be on the spinal cart? Am I correct that that is now policy in Uganda?
It is encouraged. It's just that if you have a disconnect between the policy and what's practical, then you are likely to fail in the process. So we encourage that. But like I highlighted before, you have just 4 people in that operating room working on a mother. So if you put the medication out, that means that you are, at the time the patient needs it, you're asking the anesthetist to walk out of the room to go and get the medication. So is it practical? I don't think so. I think it endangers the mother already, because this is a mother who is already having hemorrhage. So there is policy, it is encouraged, but ultimately we have to go down to each of the centers and find what can work for them.
Okay, so
Thank you.
yes, you're bringing up the fact that the context matters. And I liked the comparison that David made. There are some drugs kept in the refrigerator that are right outside the theater. And so that works in that case. It looks like, David, you'd like to respond?
Yeah, just to second what Joseph's saying, that's absolutely right. You can't have an anesthetist leave. So if your setting is that you have to physically go out, but then my question would be for those drugs that are stored out, how outside, like the succinylthonium or whatever you bring in, how do you bring it in? And so one of the solutions we've used when there's no floor nurse, when the anesthetist has to fetch them, is that they come in a little container with your drugs from outside, and the tranexamic acid sits in there, and it's not sitting on the spinal trolley. So you've got another mechanism for the drugs that were outside there. And then we find that drug is handled in a different way. What I think you've got to just make sure doesn't happen if you have to have all the drugs in your theatre, that it never gets near the bupivacaine or the spinal trolley. And we have got circumstances where anesthetists obviously don't want to leave, and so they bring them in, and they have, you just have to come up with a solution that says my tranexamic acid is sitting in that container over there, rather than storing it routinely in the theatre in a way that it could get mixed up. So I agree with you completely, Joseph. I think you're saying an important point.
Thank you. We are almost at time, so I want to take this opportunity to thank Dr. David Bishop and Dr. Joseph Kiwanka. Thank you so much for your talks, really situating where this problem lies, the methods that we can use to resolve it, to ensure that we look at this as a systems issue, not a blame game on an individual provider. And sharing the experience of how both in South Africa and in Uganda, great strides have been made. There were some other comments in the chat that, for example, in India, they're seeing that as well, but the hush culture and blame culture exists too. So we'd like to shine a spotlight on this and help all of us around the globe prevent these medication errors. We will be sending out a follow-up email to give you all the information that was shared today and the slides. And we look forward to seeing you again at the next webinar for the Postpartum Hemorrhage Community of Practice. You feel free to capture that QR code and you can join us at the Community of Practice. Bye, everyone.
All right, bye. Thank you.
Thank you.